The topic, as said Vasilis before, is slowing the progression of diabetic kidney disease. And as we said also before, CKD prevalence is very high. About 840 million people worldwide are living with CKD. And the percentage across the different continents varies between 8 and 15%. And this, according to a meta-analysis for the prevalence of CKD stages 3 to 5. If we also include stages 1 and 2 that are often undiagnosed, of course, this prevalence is much more higher. And the same is true about diabetes. About 540 million people worldwide suffer from diabetes. And there is also an estimated 44% of adults, especially in low and middle income countries, that are undiagnosed. So both conditions have a very high prevalence, are even higher if we count all the undiagnosed cases. And also, this prevalence is rising and is expected to rise until 2050 much more. Of course, diabetes is the leading cause of end-stage renal disease. About 42% of cases with end-stage renal disease are due to diabetes and followed closely by hypertension, and then all the other conditions. Cardiovascular events are the main problems in patients with CKD, and one of them, heart failure, is the main cardiovascular comorbidity in CKD patients. And as we can see here in this graph, heart failure is has a 3 times higher risk in the CKD population compared to non-CKD patients. The relative risk of cardiovascular mortality in CKD rises in parallel with a decrease in GFR and also the increase in albuminuria. But the most striking, I think, is that mortality is more likely than progression to SRD in patients with CKD. And we can see here in this graph with yellow, the yellow bars show the non-cardiovascular causes of CKD mortality as malignancies infections. The deep purple represents the cardiovascular events, and the light purple, and you see, which are more or less, represents those patients with CKD that finally progress to ESRD. If we have and put all the 3 conditions together, cumulative risk of death from a simultaneous presence of CKD, diabetes, and CVD. As we can see in this table, the presence of CKD without diabetes and CVD increases the probability of death by 2.3 times. CKD and diabetes without CVD increase this risk of death by 10 times. And if all 3 conditions are present, then this risk of death increases by 50 times. So it is imperative to screen for CKD. And we have to screen all diabetic patients, and this is depicted in the recently updated guidelines of the European Society of Cardiology, 2023, and is strongly recommended. You see the recommendation is level 1B, that all patients with diabetes are routinely screened for CKD by assessing eGFR by the CKD epi formula and UACR. The same is also depicted in the more nephrological, I would say, KDIGO guidelines. Also, these guidelines consider screening for CKD in all diabetics with UACR and an equation based either on serum creatinine or cystatin C. And a low GFR and a higher UACR or other markers of kidney disease should be present for more than 3 months to establish a diagnosis of chronic kidney disease. Also, this provides at the same time the risk stratification. The GFR and the albuminuria puts the patient into 5 categories for GFR and 3 categories for albuminuria. And as we can see in this table, increasing albuminuria and decreasing GFR is associated with an increased risk, of course, besides cardiovascular mortality, also of initiation of maintenance kidney replacement therapy. And in the very recently updated KDIGO guidelines of 2024, there is a strong recommendation, as you can see here, level 1A, that people with CKD stages 3 to 5, we recommend using an externally validated risk equation to estimate the absolute risk of kidney failure. These risk scores provide individualized risk prediction, facilitates personalized patient-centered care, and also provide a useful tool to timely but also cost-effective referral to the nephrologist. Of course, it is imperative to slow this progression of CKD, and there are many interventions nowadays that we can apply. At first, we have all the lifestyle modifications and all these that we can apply as weight loss, smoking cessation, sodium restriction, plant-based low-protein diets, exercise, and all these lifestyle modifications. We have to insist that our patients apply all these measures because they work, but on top of them, we have, of course, nowadays, during the last 5 to 7 years, a substantial number of drugs, besides the well-known for many, many years ARAS inhibitors, also new drugs, new categories of drugs, as SGLT2 inhibitors and mineralocorticoid receptor antagonists, the MRAs. All these measures and all these pharmacological interventions have the net effect of lowering intraglomerular pressure, regulating tubuloglomerular feedback, and finally reducing inflammation and fibrosis. That is the last step in kidney destroyment. Treatment of patients with diabetes and CKD, as we can see again in the European Society of Cardiology guidelines, consists of initiating and sequentially up-titrating doses of all these agents we can apply now. The general measures, I have already mentioned all the lifestyle modifications, and I start with a change in diet and nutrition. As you can see, this is a revised guideline if we compare it to the 2019 guidelines, and now it is strongly recommended to adopt a Mediterranean or plant-based diet in diabetic patients, but this also, of course, applies to patients with CKD, especially those with obesity and metabolic syndrome. We have, again, all these are strong recommendations to aggressively treat lipids, to have a tight glycemic control, and also low-dose aspirin is recommended in patients with CKD and atherosclerotic cardiovascular disease. Here we have to pay attention because CKD is associated with both increased atherosclerotic CVD, but also bleeding. And the ATTACK is an open-label trial that aims to assess the efficacy, but especially the safety of low-dose aspirin in all stages of CKD. Of course, we have to treat blood pressure to a target below 130 to 80, with maximum tolerated doses of ACEs or ARBs, and of course, combined use is not recommended anymore. RAS inhibition is well known for the past 25 years. The first studies, RENAL and IDTN, where the studies showed that ARBs can slow the progression of diabetic nephropathy. However, neither study showed benefit in composite cardiovascular endpoints, and the residual risk that remains is still high. We have a new category of anti-diabetic drugs, the SGLT2 inhibitors, and this is a meta-analysis of all large SGLT2 trials that shows benefits on the risk of CV death and heart failure hospitalizations, and also on progression of CKD. And this is unmodified by eGFR. As we can see here, the negative bars are events avoided, so the net effect is positive, and this also applies to diabetic and non-diabetic patients. And here we can see the key results from all the big RCTs assessing SGLT2 inhibitors in diabetic and non-diabetic patients. All of them proved cardiovascular efficacy, and then came the nephroprotective effect that has been proven. And now all this category of drugs is first-line therapy for CKD and independent from the diabetic status. This is shown in all guidelines, also the European Society of Cardiology guidelines, but also the KDIGO guidelines. We recommend treating patients with type 2 diabetes mellitus and CKD with an eGFR higher than 20 mL per minute with an SGLT2. And once initiated, as states the KDIGO guidelines, it can be continued until the patient starts dialysis. So the addition of the SGLT2s to ACEs and ARBs slows the progression of CKD and definitely reduces cardiovascular morbidity and mortality. However, there is still a residual risk, as we can see. And what can we do for this? We have other categories of anti-diabetic drugs, as the GLP-1s. This class of antidiabetics has also pleiotropic actions. It increases insulin secretion and insulin sensitivity and natriuresis, reduces RAS activation, has an anti-inflammatory and antifibrotic effects, and reduces body weight. A meta-analysis of GLP-1 trials in type 2 diabetic patients showed that they reduce albuminuria levels, they reduce MACEs irrespective of GFR, and all this with a low risk of hypoglycemia. Coming to the burning question, if this category of drugs slows down the GFR decline, we have yet no definite answer. We have small studies, as is this Spanish study published in the Clinical Kidney Journal in 2022. 122 patients with type 2 diabetes and CKD were treated with semaglutide, a GLP-1 RA. And in many studies like this, it was indeed shown that they improve glycemic control, they lead to weight loss, but also albuminuria decreased significantly by more than 50% in those patients with macroalbuminuria. And this is a very promising effect in terms of the renal endpoints. The definite answer, I think, will be provided when we will have the results from the multicenter flow study. This study recruited more than 3,500 patients and tested the efficacy of semaglutide in renal endpoints in patients with moderate and severe DKD. For more than 5 years, patients were diabetic with GFR higher than 25 mL per minute, and as you can see, the composite primary renal endpoint was a heart endpoint, decrease in GFR more than 50%, ESRD, or death from renal and cardiovascular cause. The interim and final analysis are awaited, but as we can see, it was implemented in the guidelines already because we have seen the beneficial effect. And this is a revised recommendation from the ESC guidelines. As you can see, in 2019, it was adjusted and in patients with eGFR higher than 30. Now it is recommended, and in patients with eGFR even as low as 15 mL per minute. An alternative to the GLP-1 is the DPP-4. There are small trials. There is one trial with linariptin that indeed showed lowering of glycated hemoglobin in patients with diabetes and CKD, but it had no effect on reduction of cardiovascular or CKD endpoints or CKD progression. Coming now to the other category of drugs, the mineralocorticoid receptor antagonists. The selective antagonist is finerenone. I will not say many things about finerenone, just a few things, because then there is a lecture after that. But it is a selective MRA with strong action and equal distribution between heart and kidney, and it slows progression of GFR by reducing oxidative stress and pro-inflammatory pathways. After the first two big trials, Figaro and Fidelio study, including diabetic patients with a broader spectrum of GFR and albuminuria, we come to the Fidelity pooled analysis, examining a total of 30,000 patients, and it showed indeed that finerenone, on top of standard of care, reduces the risk of clinically meaningful cardiovascular and kidney outcomes in patients with diabetes type 2, and this across a broad spectrum of GFR and albuminuria. It reduced the cardiovascular risk by 23%. The nephroprotective effect was sustained and independent, as we can see here, of the initial eGFR and UACR. And the benefits were seen after 12 months for renal outcomes, but as early as after 1 month for cardiovascular outcomes. And they were sustained throughout the study. So it is now in the recommendations, the European Society of Cardiology recommendations. You see a broad range of GFR and UACR, and also in the KDIGO guidelines in patients with diabetic nephropathy and the eGFR higher than 25 mL per minute. We have to be cautious with potassium. Patients with hyperkalemia are not suitable for finerenone, but it has proven efficacy as add-on therapy on top of RAS inhibition and SGLT2 for the treatment of diabetic nephropathy. As for the combination of finerenone with SGLT2s, there is limited information. The big SGLT2 RCTs had low numbers of patients that took finerenone and SGLT2 inhibitor. But the first subgroup analysis showed that the combined use does not modify safety findings from the key trials. And they also suggest that there might be a synergistic effect, as we all expect. And the pre-specified subgroup analysis of Fidelity indeed showed that relative risk reduction in the composite cardiovascular and renal outcomes and the effect on albuminuria by finerenone was similar in those taking SGLT2s and GLP-1s in the first trials of Figaro and Fidelio, and those not. And the safety profile was unchanged. In particular, the incidence of hyperkalemia appeared to be lower in those receiving SGLT2s. And this is very important. Now, the confidence study is running. It is a big study, as you can see, in 13 countries across continents, and it aims to include more than 800 patients and has 3 arms: finerenone in combination with empagliflozin, finerenone plus placebo, and empagliflozin plus placebo. And the aim is to show an additive effect, and if this effect can be shown, then an early and efficient intervention with dual therapy may be feasible. the field is very broad and many trials are ongoing. As you can see, also trials in non-diabetic CKD, as defined CKD, in pediatric populations as the FIONA, the fine arts in heart failure patients with EF higher than 40%, and many others. And coming to my last slide, I would just say not forget to advise our patients to temporarily withhold all those drugs if there are conditions with intravascular volume depletion or during major surgeries, because they all have the net effect of lowering intraglomerular pressure, especially in the beginning. And if they don't do this, then the sad man is not the patient, but is the nephrologist who has to deal, especially after this hot summertime in Greece, with many frail elderly patients in the emergency department who are dehydrated with acute renal failure and hyperkalemia. Thank you very much.